My guest today is Dr. Yilmaz, a specialist in gynecology and obstetrics. With Dr. Yilmaz, we'll be discussing a very sensitive topic that has been hotly debated in the medical world for years. The FDA's latest update on the use of hormone therapies for women during menopause has reignited these debates. Who should receive estrogen support, and for whom does it still pose a risk? Does the key to healthy aging for women lie in hormone therapies? How should women approaching menopause embrace this new phase of their lives? Together, we will shed light on many questions. If you're ready, let's begin. Welcome, Mine.
It's good to be here, Umut.
After a busy day.
Yes, the morning was quite busy. We had menopause patients in our procedures as well.
And deliveries are ongoing.
Of course, the deliveries. My husband and I became known for our work with childbirth.
Our specialty is called Obstetrics and Gynecology, so it wouldn't be the same without deliveries.
Ongoing?
I think it's the most sacred, well, all of it is sacred, but, one of our special sacred duties is giving life to a living being.
It's the most enjoyable part of our profession. It doesn't feel like treating a disease, which is why we've happily done it for years.
I sometimes see those children grow up, and maybe they themselves, right, are training to become obstetricians, becoming doctors.
I've been delivering babies for 20 years, Umut. The children I delivered back then now have their own children, some of whom are studying medicine.
That's special.
Enjoyable.
For us, the same thing applies to circumcision, but, right? Childbirth must be a much, much different feeling.
Of course, taking a life from scratch, from a single heartbeat to birth, and then years later seeing them all grown up, it's truly an indescribable thing.
Yes.
I hope it continues like this for years to come.
Let's talk a bit about menopause today. Because over the last few weeks or months, even though it's not really my specialty, it's a topic that has certainly come across my desk. The FDA, the US Food and Drug Administration, recently made an update. In this update, there's something called a black box, a warning section. They removed it in relation to hormone therapies. Of course, this made a big impression. It was a widely discussed topic on social media as well. It was called a historic event. Do you think it's a historic event? What does this mean? The removal of that black box, what is it exactly? Could you shed some light on it for us?
First of all, Umut, let me put it this way. What was that black box? What did it mean? In 2002, there was the WHI study, which was suddenly terminated, a study on menopause. It showed that because very advanced age groups were also included in the study, it showed an increase in diseases like breast cancer, uterine cancer, heart conditions, blood clots, and stroke. And after that, the FDA placed that black box warning on hormone medications abroad. This meant a drug that poses a potentially serious risk or a life-threatening risk. Yes, last November, the black box warning was removed from a group of drugs. But not from all of them.
No, not from all of them.
Not from all of them. Is it a historic event? I didn't see it that way, Umut. I followed it for a while. On Instagram, I saw what was happening in our country. Things like an incredible path has opened, a historic event were written, and now some of those doctor friends are silent. But that's not what it means. The good part is this. For us women, and I'm speaking as a 45-year-old woman myself, yes, the benefits of hormone replacement have been acknowledged. It became clear that as women's life expectancy increased, their rates of osteoporosis, dementia, and cognitive decline also began to rise.
Yes.
The FDA has now accepted that hormone replacement therapy, when started at the right time, which we'll discuss later, is very beneficial for these conditions.
That's a great development.
Absolutely. Yes, it's not a historic event, but it's a very good development. After 2002, we had a bad period of 21 years where we couldn't prescribe it. Yes, now we'll be able to prescribe these drugs to start hormones. But it doesn't mean, and please, I tell this to my patients as well, that every woman or any woman who wants it, or that every gynecologist can just start or receive hormone replacement therapy. It's not like that.
We'll probably talk about this at length, but I'd like to start with the basics.
Of course.
What exactly is menopause? And what are the findings, the complaints that signal a woman is approaching menopause? I'd like to start from the beginning, from A to Z, so to speak.
Because there are always misconceptions or things that are not well known. First, we have to accept menopause as a biological process. Just as we start menstruating at age 10, 12, or 13 and go through a reproductive period, that period will come to an end, and after that, we will enter the postmenopausal phase. Menopause is the beginning of the period when our ovaries cease to function, and our estrogen and progesterone hormones decrease and, I can say, completely disappear. It's an entirely biological phase.
So it's a phase unique to women.
Yes, a phase unique to women. So how does a woman know she's entering or about to enter menopause? The first and most prominent sign that many women experience is changes in their menstrual cycle. Generally, the most common change is when 28-day cycles shorten to 21 days and the flow becomes heavier than normal. That's the most common, but it's not the only one.
The interval shortens a bit.
Yes, the interval shortens and the flow increases. That's the most common menstrual change. But the opposite can also happen, Umut. For instance, having a heavy period and then a sudden decrease in flow. Or, while having a period every 28 days, the intervals might lengthen. Because everyone's baseline estrogen level is different.
So there can be various findings, but an irregularity begins in her usual menstrual system.
That's the first thing she might notice. If she entered menopause through other means, like extreme stress or surgery, that's also possible. Especially for those who enter due to extreme stress, another sign she'll notice is hot flashes. I've been dealing with menopause for a year now, Umut. The most prominent complaint from my patients is this: brain fog, which we'll talk about. A decline in cognitive functions. Doctor, I start something and leave it half finished. I can't complete what I start. Or I have no tolerance for my husband, my child, my colleagues, my clients, or my patients. I've started taking antidepressants. I have very serious anxiety and stress. I have a fear of death, anxiety about the future. These are the cognitive effects. Or even though I've dieted, eaten less, and exercised, I can't lose weight. Especially fat accumulation around the waist, abdomen, and hips.
So the metabolism is also affected.
Absolutely. Insulin resistance increases. These are what patients notice. These are the most obvious ones.
So the decline and change in cognitive functions naturally reflect on the person's mood, right? It's a situation that also reflects on their mood.
Absolutely. A shift towards serious antidepressant use begins in this age group.
And of course, there will be some effects on their immediate circle, their family, their children, right? Absolutely. So, are there any blood tests to determine if someone is about to enter, is entering, or has entered menopause?
I wish there were, Umut. Everyone has that expectation to find out when they'll enter it. Unfortunately, there aren't. I mean, of course, we look at estrogen and FSH, but these fluctuate. For example, this month, there's infertility, women in their 40s who want children. I might look at a woman this month and say, your FSH and estrogen are fine, you can get pregnant. She says, doctor, I still haven't gotten pregnant. You check again, and this time her FSH is very high and her estrogen has dropped.
Picture shifts instantly.
Of course, because it fluctuates so much during the perimenopausal or premenopausal period, you can't give a definite timeline. Hot flashes can come in bouts. If a woman over 45 has menstrual irregularities and hot flashes, she is in perimenopause. You don't need to guarantee this with any laboratory test.
It's not really
necessary. There's no need to do it.
So it's quite clear that blood tests are not a determining factor at this point. Well, we talk about hot flashes in menopause. Of course, as men, we can't really perceive it. But what is it like? Is it really a symptom that's hard to tolerate? And what causes this symptom?
Let me answer that first. It's a situation that really disrupts social life and is very difficult to tolerate. I often see a patient in front of me sweat and change color 5 times during a half-hour consultation. So if we ask how this happens, why does it happen in women and not in men? The density of estrogen receptors in the female brain is much higher. What regulates our body temperature is a center called the hypothalamus. This is our heat thermostat. When the saturation of estrogen receptors decreases, meaning when there isn't enough estrogen in the body, the thermostat range there starts to narrow. Normally, the body starts to respond at 0.4, 0.6 degrees, but here a misperception begins even at 0.1, 0.2 degrees. The body says, my body temperature is rising too much, this could harm me, and it tries to cool down. What happens in this cooling mechanism? Especially in the head, neck, and chest, there's a very significant vasodilation, an overactive functioning of the sweat glands. an increase in heart rate, a spike in blood pressure, and along with it, severe anxiety and shivering attacks begin. And we don't know in which woman this will happen, how much it will happen, or how long it will last. Sometimes it can last for 30 seconds, sometimes it can last up to 5 minutes.
In bouts.
Of course. And unfortunately, 70% of menopausal women experience this complaint. It's been shown that while these complaints can last a few years, they can also persist for up to 7 to 10 years. I mean, back in the day, about 20-something years ago when we were residents, they used to say it subsides after the 5th year. Some women still have these symptoms in the 10th, 12th, or even 13th year of menopause.
Yes. Well, there are certain hormone medications we use for our prostate cancer patients. We see this symptom in them. So, of course, I know it's a very uncomfortable thing. But this is something every woman actually sees and experiences during menopause. It's a condition we induce medically, though very rarely, in men, and even then, it causes a great deal of discomfort.
70% serious.
A very serious number.
Yes.
Of course, menopause is also a psychogenic process, isn't it? I mean, I think every woman perceives it differently. Could some see the end of their reproductive functions as a relieving factor, perhaps? I mean, there's the thought, I no longer have a chance of getting pregnant. I'm guessing, of course, this is my interpretation. I mean, as menopause approaches, the fear of pregnancy might even increase because the other children may have grown up. Women might also be very wary of a sudden and unwanted pregnancy. Maybe menopause, and I say this in quotes because I don't know, could perhaps be a psychologically relieving factor for them. Perhaps.
Absolutely, well, of course, certainly.
But it's a condition that also affects one's mood, that brain fog.
Of course, it's two-sided. It has positives and negatives.
Not negative.
Of course. But whether it's evaluated positively or negatively depends on many things, like the woman's past, her socio-cultural level, whether she's on hormone replacement. Now, let's talk about the positive side first, because we're always focusing on the negative. For example, PMS is a very serious syndrome. Premenstrual syndrome, premenstrual tension. The end of these, or dysmenorrhea, the end of menstrual cramps, has a very serious positive effect for many women, because these are things that disrupt their social lives.
So it can make some women say, thank God.
Absolutely. Or in patients who bleed very heavily, who have been recommended surgery multiple times, let's remove your uterus for menstruation to stop, for ferritin and hemoglobin levels to rise. It affects these positively. In some women, there's an incredible return to self, a return to their essence, proving themselves, focusing on themselves. These are all positive aspects. Some women, as you said, have the thought, I won't get pregnant anymore. Unprotected sexual intercourse. There's a group that enjoys the pleasure of sexuality that turns this to their advantage. But unfortunately, Umut, this group is small, a very small group.
So for some women, life begins anew.
Absolutely. I have a wonderful patient who calls it a second spring, who says, I've started my second spring. But this percentage is small. Unfortunately, the negatives are more prevalent.
And of course, when hormone therapy is started, the main issue is, yes, eliminating these symptoms, the hot flashes, which is a very, very positive point regarding quality of life. But beyond that, it also has aspects that concern life itself. It also has aspects that concern healthy aging, definitely. So I guess that's why it's such an important topic.
Of course, that's the biggest reason the FDA removed the black box, proven osteoporosis. First and foremost, it was shown to significantly reduce osteoporosis, yes, exactly, bone loss. Estrogen has very serious positive effects on the cardiovascular system up to age 60. When you reduce that, because we always say, from the moment a woman enters menopause, her risk of having a heart attack is higher than a man's. Right now, the number one cause of death in women is heart attack, It's higher than in men because of the lack of estrogen. Plus, dementia. Because the estrogen receptors in the brain aren't saturated, the rate of dementia in women is now twice as high as in men. That's why. And a woman's life now spans 80, 85, 90 years.
They have an advantage over men.
Absolutely. Women. We don't just leave women in their 60s anymore like we did 20 years ago. People used to say, she's 60 in menopause. It's not a big deal. Don't give her medication. But now, Umut, people can live to 80 or 90 just getting by, or they can live comfortably. Hormone replacement helps women live this age comfortably.
Of course. We're in Antalya, a tourist region, right? We encounter many foreign residents. Then people say, wow, women and men over 75 look so vigorous. So a significant portion of them are probably on hormone replacement, although of course their background, genetics, sports and diet have many effects. But before starting this hormone therapy for a woman, she certainly needs to be screened. This treatment isn't and can't be given to everyone who comes in, right? There must be a medical rule, a principle for it. What tests should be done on whom? What stages should they go through?
For me, it takes at least an hour to an hour and a half when I first see a menopause patient before starting hormone replacement. A physical examination is absolutely necessary. You have to take a very good history. Is there a history of breast CA, a family history of breast CA, ovarian or uterine cancer? Has she ever had a stroke, a clot, a pulmonary embolism, a cerebral embolism, or is there a family history? We need to go back to her pregnancies. Does she have recurrent miscarriages, which would suggest a clotting disorder? Does she have migraine attacks, vertigo attacks? These must be questioned. Her pregnancy history must be questioned. After that, a complete blood count is a must. The most important for us, Umut, is the lipid profile. That's a must. Liver functions, kidney functions, ferritin, hemogram, these are the basic tests that must be requested.
And these need to be within normal physiological limits.
Exactly. And if they're not, they need to be brought to a physiological limit before starting hormone replacement. Imaging is very important for us. As obstetrician gynecologists, we do the gynecological imaging ourselves. Is there an ovarian mass? She says she's not menstruating, but is there any endometrial thickness? Maybe this person is sick. The endometrium SE candidate has a change called perplaise. With SORMON, it progresses. These need to be examined. What is the condition of the myons? We need to look at it. Second on the list is breast image is absolutely necessary. If a mammogram is required, a breast ultrasound should be performed, and if necessary, a general surgery consultation should be sought.
Actually, there's a lot of preparation involved.
Absolutely, absolutely. Apart from that, if some time has passed since menopause, it is absolutely necessary to have a bone densitometry test. Is there osteoporosis or early stage osteopenia? We need to see these things. If you suspect a blood clot, additional blood clotting tests are needed for the patient. Plus, lately, is there anyone saying we shouldn't do it anymore? For example, is there basilar artery insufficiency? Or are there any records here saying it is absolutely necessary to request cord drill balls?
So maybe a few weeks before making a decision.
Definitely. Sometimes it can even take a month, depending on the nature of the mutation.
Yes. So these are interesting and certainly important topics. So what is the result of this assessment, for example? What percentage of women? It appears that treatment can be started. So I'm asking about your own experience, especially.
No matter how you look at it, I'm starting from 70% to 75%.
Quite high.
Quite high.
So it can be said that the groups we couldn't start with have now reached a point where they can begin after certain treatments and processes. Of course not, right?
For example, there is serious liver dysfunction. There is a serious lipid elevation or issues with her endometrioma. Once these are resolved, we'll discuss them with another group soon. We can also restart treatment for other patient groups.
Yes. So here we're mostly referring to estrogen, I presume, but which forms do we prefer? As far as I know, there are patches, creams, injections, and pills. So which one is suitable for which patient, or what is the most appropriate and best option? What is the approach here?
Let me start by saying this. The black box designation has been removed from the group's oral performances. Transdermal and oral forms. Let's still talk about bioequality maybe in a bit if you'd like. Bioequalitarian doesn't say anything boastful about the hormone. That's still up to us. But in my own clinical practice, I use gels more often. But transportation is very difficult, either as a magistral or if the patient can bring it from abroad themselves. Unfortunately, it's not available in Turkey. I'm having it brought because it's the most reliable one. One of the best things about gels is that you're bypassing carousel. Adding estrogen and progesterone to the blood prevents clotting and can increase breast blackness.
Same concerns. Regarding testosterone gels in urology, exactly. Unfortunately, we are having major difficulties accessing it. Definitely.
They can come from abroad because their dosage is fixed. How much estrogen is in one puff? Transdermal treatments are no longer available in Turkey. We had air conditioners recently. It's okay to mention his name. He was the only one. It has been removed. We can't reach them now. I use Majesticel or original gels if I can get them as estrogen.
Yes, even when we make decisions, there are points where we struggle.
And access. unfortunately. Turkey has a very serious radiation shortage, but our hormone replacement therapy doesn't end with just estrogen. Except for patients in the group without a uterus, we always support them with progesterone. Hopefully we'll talk again someday. When the latest meta-analyses came out, the study said that progesterone should be given even if the woman does not have a uterus. Because to protect the blood vessels, to protect the brain, to protect the breast, it is absolutely necessary to balance estrogen and progesterone.
They're sibling hormones, after all, definitely, relative to each other. Not just pure estrogen, but estrogen, progesterone.
The combination needs to be balanced.
Then there are vaginal estrogens, which we are also familiar with. Can these be considered hormone therapy? I don't know. I don't think that's what was meant. But I also know that it has very positive effects on the vagina and on a person's quality of life and sexual health. Is vaginal estrogen therapy also a form of hormone therapy?
It is not part of hormone replacement therapy, but it's a treatment we find very frustrating during menopause. In your field, that drug group is already in common use. Very comfortable. It really does significantly reduce complaints in women, especially those related to vaginal dryness. I'm sure it's too much for you. Many patients avoid sexual activity due to vaginal dryness and pain during menopause.
Pain and dryness during intercourse?
Definitely, because it increases collagen and because it increases hydration. A significant relaxation effect leads to an increase in sexual desire in women. It doesn't increase libido. That's a completely different matter. That's your topic anyway, you forgot about it. It doesn't increase libido, but it reduces pain, thus regulating sexual desire.
Of course, it will indirectly benefit him as well.
Blood, we have 3 types of estrogen. This is what we call type 3 estrogen. It doesn't enter the bloodstream. Even if it passes, what were we afraid of? It was the breast, the uterus, the liver. It has no effect on them. There is no systemic damage. I even talk to general surgeons, and if they deem it appropriate, they treat breast patients. Antiparchive, many of them are young patients and have entered menopause. I also use vaginestrogen.
Very good. So, as far as I know, it's supportive even in cases of stress incontinence, right? I know it can even reduce urinary incontinence symptoms because it supports the vaginal mucosa and underlying tissues.
Not a primary treatment. You know it too, but does he support it? Especially in women who have not previously had organ prolapse and have not had a vaginal birth, we are reducing it somewhat because it supports the lower urethra at 1.3 liters. But I'm not including this. I'm not including this in primary treatment. I am providing supportive treatment. It could be a C-link. It could support our suspension currents.
Severity?
Sure.
Pelvic floor physiotherapy.
It could be. Or, as you know, we've now incorporated laser and HIFU into our very serious practice. These can be combined with each other. PRP treatments can be combined with hyaluronic acid.
As is the case in many areas, it's the same for us. Combination therapies yield better results. Using them in combination rather than as a single therapy, synergistic, it certainly creates an impact. You mentioned it earlier, but it seems that women who have had their uteruses removed and those who haven't yet are 2 separate groups. But are the approaches here any different? In hormone therapy?
Of course. As I said, before the latest meta-analysis is fully published, we still consider them as 2 different groups. For a woman without a uterus, you can give only estrogen. Since there's no uterus, there's no need to protect the endometrium, which is normally protected by progesterone from hyperplasia and cancer risk. For these patients, you can just give estrogen. Progesterone isn't needed. This group is less risky. Why is that? Let me explain it this way. Because with breast CA, we're always afraid of estrogen, right? But actually, in hormone replacement, what increases breast CA is progesterone. So since you won't be giving this patient progesterone, you're not increasing the risk of breast CA. If 2 patients come to me, one with a uterus and one without, and I have to give hormone replacement, which one would you prefer? Which would be easier for you? The one without a uterus. Because for now, I can just give her estrogen and be done. I have no more worries about the breasts. But in a patient with a uterus, I absolutely have to protect the uterus. So I have to give progesterone. And the choice of progesterone is very important in order not to increase the risk of breast cancer.
These are delicate balances, really sensitive topics.
It's personalized.
Seriously, it requires a professional perspective. It seems that way. Hormone therapies are like a double-edged sword.
It can go either way. It can go either way.
So of course it's beneficial to be very careful. So, I mean, of course, for a woman in menopause, there are just medications, hormones, supplements, and so on. But there's also this thing called lifestyle. For these women, it's a new period, a new life for them. To age healthily, besides medications and hormones, what supportive things do you recommend?
First, if their living conditions aren't suitable, they need to change them. The most important thing is nutrition, Umut. During this period, insulin resistance starts in perimenopause due to estrogen imbalance. This resistance has been shown to clearly increase inflammation in the body. So to overcome this, the number one thing we need to do is regulate nutrition. There's something called sarcopenia, you know. We always focus on the bones, but the main thing is we shouldn't have muscle loss so that we can also protect the bones. Therefore, she must increase her protein intake. She'll reduce carbohydrates and gluten as much as she can. There's the microbiome. I mean, I really place great importance on the intestines. When I first talk to patients, they look at me like, what's going on? That's our immune system. She'll get her fiber to protect her intestines, and she'll definitely have a regular diet with kefir, probiotics, and yogurt. She'll exercise. She needs to do weight training at least 2 days a week, or even 3 if possible.
Not walking, to support her muscles, exactly.
For cardio to protect the heart at least. I usually say it like this to make it understandable. 150 minutes of moderate paced walking or light jogging, a weekly cardio of 150 minutes.
Perfect. Those are the keys to healthy aging, really.
Actually, these are rules we all know but don't follow.
You don't even need to be in menopause for this.
Right? You should start these in perimenopause. For example, insomnia. Sleep hygiene is very important. I tell them, you're going to bed at 11, like I'm explaining it to a child. Because it's related to melatonin release and other hormones. Sleep hygiene is very important. I'm always embarrassed to say this, but I wonder if stress can be reduced in this country. It's necessary to reduce stress. Because I recently received a study a few months ago. You can give as much hormone replacement therapy as you want. The benefit a patient actually receives from hormone replacement if they have chronic stress. It's decreasing by 50%.
I also mentioned it on air. Walking is a type of exercise that I personally do as a form of physical activity too.
Definitely.
While walking, your chances of thinking negatively are decreasing. This is a proven fact. Therefore, perhaps to reduce stress, that is to increase muscle strength, so it's not just a simple walk. In nice, clean weather, of course, the conversation is about environments with traffic and honking horns. Hiking along the coast or in quiet rural settings can offer a lot, definitely. It could be meaningful. So she's entered menopause. So this hormone therapy should be started at a specific age. Or are there age criteria, such as whether it should be started after a certain age?
It exists. We should be flexible with measures studies have in place later. The most relevant period is 45-50 years old. Or let's put it this way, the first 2 years of menopause. I think it would be much better if you started during perimenopause, which is how I started for myself. That's how I start with my patients too. But you couldn't catch them. Perimenopause, it was incessant, exactly. Their irregularities started, mood changes started, progesterone levels dropped. It makes more sense to start when estrogen levels are high on this scale. If treating a patient in menopause, the effect is maximized by starting within the first 2 years, either at age 45-50 or within 2 years of menopause. By effect, I mean the heart. These are the periods when vascular protection, dementia prevention, bone protection, and mammary gland protection are at their maximum.
It is most useful.
That period, definitely.
We skip that period. Let's say the person couldn't reach a doctor for some reason, and because of these concerns, medication couldn't be started. It's impossible to even begin, right?
It can be started up to the age of 60. It can be started in the first 10 years as well. 60 years of age or 10th day of menopause. It is not recommended to start now after the following year, because this time positive estrogen levels have serious negative effects on both the brain and the cardiovascular system. It has been shown that it increases the rate of blast formation and increases the ejection of blasts. So what's being seen right now is that what they call menopause, starting at age 10, is now also starting in women over 60.
It just occurred to me. That's why I'm asking. There's also the use of low testosterone, I think, in women, of course. Isn't that enough?
There are testosterones that both protect muscle mass, reduce sarcopenia, and increase libido. You know better than me. Mixed with several hormones. Vaginal is used to increase sexual desire. For example, in America, hope is interestingly represented by a few things I follow. There is a gynecologist, a female gynecologist. During the perimenopausal period, we typically recommend progesterone, front row. They recommend testosterone, and they use them too, transferring testosterone.
That's an interesting statistic. There are still many topics to discuss and research. So, let's say a woman has a history of breast cancer or a clotting disorder. Of course, we unfortunately can't start hormone therapy for them, at least with our current knowledge, right? That's the consensus. So, for these women to reduce their symptoms, is there anything we can do, or are there new medications?
There are. Let me first talk about the older ones we've been using for years. What are we trying to reduce? Well, impairments in cognitive functions, anxiety, and most importantly, hot flashes. SSRI groups, they're still in that category. But with those, I always say this. If the patient is taking tamoxifen, there are the paroxetine and fluoxetine group SSRIs. Please do not use them because they reduce the effectiveness of tamoxifen. We can use gabapentin. There's an antihypertensive drug called clonidine, and we make use of its side effects. But these are only about, 30, 40, or 50% effective. But more recently, there's a drug that hasn't entered Turkey yet. It's what we call a neurokinin 3 receptor antagonist, which is a receptor in the brain. When you antagonize it, it's been shown to significantly reduce hot flashes. Unfortunately, it's not in Turkey. But this group is 70 to 80% effective in reducing hot flashes, especially in the breast cancer group.
Oh, that's great.
That's very promising. It's very significant. It's almost as effective. It gives a rate close to that of estrogen replacement therapy. It increases serotonin. It increases dopamine, and it blocks neurokinins. That's why we're hopeful for this drug. The Menopause Association says the same, that it will enter Turkey soon. If it does, these patients will be much, much more comfortable.
Yes, our patients are special patients who have had certain traumas. So, to help them, I hope it comes to our country as soon as possible, of course. Yes, hormone therapy has many, many benefits, but there's also the psychology and quality of life aspect of it. And these don't just affect women, they also spread to men sooner or later.
They live together, Umut, a woman's menopause.
How can you separate woman from man or man from woman?
Exactly, they experience it all together.
One's mother, another's wife.
One's child, another's sibling.
Yes, very different dynamics are at play. Yes, it was a very nice conversation. Is there anything you'd like to add? I'm trying to think what topic I might have missed, but...
There's really a lot to talk about. I hope there will be days when we can talk in more detail. Let me just briefly say, without taking too much of your time, I'm currently on hormones, I use them myself. There's no harm in saying that. I started with progesterone, I'm in the perimenopausal period. Recently, I also started a very small amount of estrogen. Estrogen is also given in the perimenopausal period. I support bioidentical hormones for now. That is vaginal progesterone along with oral at a minimal level, and I support transdermal estrogen. Let's meet our patients during perimenopause. I recommend this, absolutely, because this time when cognitive functions decline and anxiety, stress, and worry about the future increase is actually the perimenopausal period, Umut. Because there's still some ovarian function, estrogen and progesterone fluctuate, so our personalities do too, and many divorces happen then. Most of my patients come to me after divorce.
Yes, intolerance.
There is. They can't recognize themselves. They can't make sense of their situation. That's why I say let's meet during the perimenopausal period. Let's provide our support. Let's talk.
Maybe we can prevent separations and divorces.
I believe that. I really do. Because the patient gets divorced, but she doesn't know why. She doesn't know why she can't tolerate things anymore. I'm in favor of starting treatment in the perimenopausal period, and I'm in favor of continuing it through menopause. I say this to my patients. If your thyroid function is impaired, do you take thyroid medication? Yes. If your pancreas isn't working, if you're diabetic, you need to take insulin. Do you take it? Yes. Then if you're in menopause, your ovaries are no longer just reproductive organs. They are endocrine glands. If it's appropriate for you and you want to have a quality life, then you have to take estrogen and progesterone that is personalized for you.
Exactly. That's my conclusion. Thank you.
Thank you.
Hope to see you again.
Thank you for all your work. Thank you very much.